welcome to the deep dive. Today we're getting into something pretty interesting, maybe even a bit controversial in the medical world. Neurogenic Thoracic Outlet Syndrome. NTOS for short.
That's right. And we're digging into it using the chapters from Rutherford's Vascular Surgery and Endovascular Therapy as our guide.
Yeah, this isn't your standard medical mystery. We're talking about nerves getting squeezed, basically, in that tight spot between the collarbone and the first rib.
Yeah.
And it causes, well, a whole bunch of different symptoms.
Exactly. And because of that, there's quite a bit of debate sometimes about how you diagnose it, how you treat it. Some folks have even questioned if it's, a distinct condition at all.
Okay, right. So our mission today, for you listening, is to really break down NTOS. We want you to get a handle on what it is, what might be causing it.
How doctors try to figure out if someone actually has it.
And the ways it's managed currently.
Yeah.
Including, when surgery might come into play, and why there's that debate we mentioned.
And like you said, we're leaning heavily on a dedicated chapter in Rutherford's. It gives a really comprehensive look, covering everything from the basic anatomy right through to surgical outcomes. It's solid stuff from a major vascular surgery text.
Great. So let's dive in. First things first, the anatomy. What exactly is this thoracic outlet? Where are we talking about?
Okay, so picture this really critical passageway. It's located between the base of your neck and your armpit, sort of. It's bordered by your collarbone, your first rib, and some important neck muscles.
So it's a space defined by bone and muscle.
Right, bones and soft tissues. And through this relatively small space, you've got the major nerves, arteries, and veins going to and from your arm. It can get pretty crowded in there.
And not just a simple tunnel, I imagine.
Definitely not. The soft tissues are key, especially the scalene muscles in the neck. They form a kind of muscular triangle that the nerves and artery have to pass through. Plus, you have ligaments and fascia, that connective tissue, also forming the boundaries.
Got it. Now, the nerves, since we're talking neurogenic TOS, which nerves are the main players here? The ones causing the trouble?
The big one is the brachial plexus. Think of it as like a major nerve highway. It starts from nerve roots in your neck, specifically C5, down to T1, and these roots bundle together.
Okay.
Then they travel through the thoracic outlet and branch out to control, well, basically everything in your arm and hand movement, sensation, the works.
And are there other nerves nearby that can get involved?
Yeah, definitely. The phrenic nerve, which controls your diaphragm for breathing, runs nearby. The long thoracic nerve, important for shoulder blade stability, is also in the vicinity. And the cervical sympathetic chain, part of your automatic nervous system, passes through as well. So compression could potentially affect those too, though the brachial plexus is the main focus for NTOS.
You mentioned the scalene triangle earlier. Why is that spot so critical?
It's a major pinch point. It's formed by two of the scalene muscles, the anterior and middle scalenes and the first rib underneath. The brachial plexus nerves and the subclavian artery have to squeeze right through this triangle.
Ah, okay. So if anything narrows that triangle.
Exactly. If those muscles get tight or swollen, or if there's an anatomical variation, it can directly compress the nerves and sometimes the artery passing through.
And our source mentions that people aren't all built the same way in this area. What kind of variations do we see and how do they contribute?
Right. This is really interesting. The standard anatomy textbook picture, it's actually not even the most common setup. Lots of people have small differences.
Like what?
Well, things like an extra little muscle called the scalene minimus. Sometimes it runs right through the brachial plexus nerves. Or you might have extra fibrous bands like dense connective tissue straps crossing over the nerves.
Oh.
Surgeons doing NTOS operations often find a really distinct tough band right over the T1 nerve root where it comes out. These little variations can basically make that passageway inherently tighter.
So it makes the nerves more vulnerable to getting squished.
Pretty much, even during, normal movements, if the space is already a bit compromised.
So some people might just be anatomically predisposed.
Yeah.
What about bony issues? You mentioned cervical ribs in the outline.
Yeah, cervical ribs are a classic example. It's an extra rib growing from the C7 vertebra in the neck. Not super common overall, maybe 1% of people. But you see them much more often in patients who actually develop TOS symptoms.
They're not all the same.
No, they vary a lot. Some are fully formed ribs that might even fuse with the first rib. Others are just little bony nubs, maybe connected to the first rib by a fibrous band instead of bone.
Okay.
And besides cervical ribs, you can also have abnormalities of the first rib itself. Maybe it's shaped funny, or maybe it healed weirdly after a fracture, creating extra bone called callus that narrows the space.
The chapter also mentioned histopathology, looking at the tissues under a microscope.
Yeah.
What did they find in the scalene muscles of NTOS patients?
This is fascinating because it gives clues about the underlying process. They consistently find changes in the scalene muscles. For one thing, there tends to be a higher proportion of type I, or slow twitch, muscle fibers compared to the normal mix.
Okay, slow twitch fibers. What about the fast twitch ones?
The type 2, fast twitch, fibers often show signs of atrophy, like they're wasting away. There's also usually more connective tissue within the muscle, something called endomesial fibrosis. And sometimes they even see signs of issues with the mitochondria, the energy factories in the cells.
Right, so what does all that microscopic stuff suggest? What's the takeaway?
Well, it strongly points towards chronic stress or injury to those muscles. The shift to slow twitch fibers, the wasting of fast twitch, the fibrosis, it looks like the muscle has been trying to adapt to being constantly tight, maybe spasming or under strain.
Which fits with the idea of compression or irritation.
Exactly. And it lines up really well with the fact that a lot of NTOS patients report some kind of trauma or repetitive strain history.
That brings us perfectly to the causes, the etiology. It sounds like it's usually a mix of things.
That's the key idea from the source. It's typically not just one thing. It's often a combination of having maybe a slightly susceptible anatomy.
Like those variations we talked about.
Right, combined with some kind of trigger, often neck trauma or repetitive strain. It's interesting, though, even people with what we'd consider normal anatomy can develop compression, especially with certain activities.
What kind of activities?
Things that involve keeping your arms elevated for long periods or forceful or repeated neck movements. Think overhead work, maybe certain sports, even prolonged computer use.
So everyday stuff could contribute, potentially.
But the chapter makes a good point. Those congenital variations, the extra muscle bands, the cervical ribs, they usually don't cause NTOS all by themselves. It's more like they lower the threshold.
How so?
They make it more likely that an injury or strain will cause symptoms. If the space is already a bit tight, even a smaller incident can push things over the edge compared to someone with more room in there.
Makes sense. And trauma seems like a really significant factor. What kind of trauma are we talking about? Is it always a big accident?
Not necessarily a huge accident. Many patients do report a specific injury, maybe whiplash from a car accident, a fall, or an injury to the head, neck, or arm.
Okay.
But what's really interesting is that often there's a delay. The NTOS symptoms might not pop up for days, weeks, maybe even longer after the initial event, which can make it hard to connect the dots sometimes.
Yeah, I can see that.
And then there's repetitive strain. That's a big one, too. Think about jobs or activities involving prolonged postures, like desk work with poor ergonomics or assembly line work, musicians, anything that puts sustained strain on the neck and shoulder muscles.
Leading to muscle fatigue, inflammation, and then nerve compression.
That's the thinking. The scalene muscles get overworked, tighten up, and squeeze the nerves passing through or nearby.
And what about just posture? Getting older?
Absolutely a factor. The book mentions age-related postural changes, things like shoulder slumping forward, the head drifting forward, that classic stooped posture. That definitely changes the mechanics of the shoulder, girdle, and neck and can absolutely contribute to narrowing the thoracic outlet over time.
Okay, so we've got the anatomy. The potential causes a mix of predisposition and triggers. Now let's talk about how NTOS actually presents. What does a patient experience? What are the clinical findings?
Right, the diagnosis. It really hinges on recognizing a characteristic pattern of symptoms and history. Demographically, the source notes it's most common in women, often between the ages of 20 and 40.
Any reason why?
It's not entirely clear, maybe hormonal factors or differences in anatomy or posture, potentially. There's also often an association with activities involving heavy lifting or overhead arm use, as we mentioned.
Okay.
But it's really important to stress NTOS can happen even without obvious anatomical issues or a clear trauma history. And there's no known inherited pattern or specific medical condition that predisposes you.
So what are the main symptoms people complain about? What should make you think NTOS?
The big ones are pain and paresthesia. That's the medical term for tingling, pins and needles, numbness, sometimes even a burning sensation.
And where do they feel it?
This is key for NTOS. It's typically not confined to the area supplied by just one single nerve, like you see in carpal tunnel or ulnar nerve problems. Instead, patients often describe symptoms throughout the hand and arms, sometimes shifting around.
So more diffuse.
Exactly. Diffuse, widespread through the upper limb, and very commonly the pain radiates. It extends up into the shoulder, the neck, the upper back, even the chest wall sometimes. For many people, that referred pain in the neck and shoulder area can actually be more bothersome than the arm symptoms.
And can it affect both sides?
It can, yes. Bilateral symptoms aren't uncommon, though it often starts on one side.
So that wide distribution helps differentiate it from, say, carpal tunnel at the wrist.
It does. Carpal tunnel usually involves the thumb, index, middle finger, maybe half the ring finger. Ulnar nerve issues affect the pinky and part of the ring finger. NTOS tends to be much broader.
What else is characteristic?
Almost universally, symptoms get worse with specific activities, especially things that involve raising the arms overhead or using the arms and hands for sustained periods. Even simple things like holding a phone, driving, or typing can aggravate it. And lying down flat, especially with arms overhead, can often trigger symptoms and wake people up at night.
The source also mentions headaches. How do they fit in?
Headaches are pretty common, yeah. The thinking is they're usually referred pain, likely coming from spasm in the neck and upper back muscles, the scalenes, the trapezius. It's often felt in the back of the head, the occipital region.
Is it related to migraines?
Not directly, no. While someone could have both NTOS and migraines, there isn't evidence that NTOS causes migraines or vice versa. It seems to be more of a tension-type headache related to the muscle issues.
What about actual muscle weakness or visible muscle wasting? Does that happen?
You know, true measurable weakness and significant muscle atrophy are actually pretty rare in NTOS.
Why is that?
Probably because the nerve compression is often intermittent. It comes and goes with position and activity rather than being a constant, severe pressure that would cause irreversible nerve damage quickly.
So when patients feel weak,
Right. What they often perceive as weakness is more likely related to the pain. They avoid using the arm because it hurts, or they can't sustain effort because of the discomfort. Making that distinction is important during the exam.
and the overall impact, it can vary a lot.
Huge variation. Some people might just have mild positional complaints, their arm tingles when they dry their hair, something like that. But for others, especially if it's been going on a while, NTOS can be severely disabling.
Affecting work, daily life.
Absolutely. It can make it impossible to continue certain jobs, hobbies, even basic things like dressing or cooking. These are often the patients who've seen multiple doctors, tried various treatments without much luck. Understanding the functional impact, what specific activities trigger symptoms, especially work-related ones, is crucial.
Now things get a bit more complex, right? The chapter mentions vascular symptoms and complex regional pain syndrome, CRPS. How do those relate?
Yeah, this is an important overlap. Some patients, particularly those with more severe or long-standing NTOS, might notice changes in hand color. Maybe it gets pale or bluish, or it might feel unusually cold.
Is that poor circulation?
Not usually true arterial insufficiency where the artery is blocked. It's more often related to dysfunction of the sympathetic nerves that control blood vessel constriction and dilation, sort of like vasospasm.
Okay, and the CRPS connection.
In some really severe cases, the chronic nerve irritation from NTOS seems capable of triggering a state that looks very much like complex regional pain syndrome type I. This involves persistent vasospasm, swelling, skin changes, and really extreme sensitivity where even light touch is painful.
How do you sort that out?
Vascular lab studies can help assess blood flow, and sometimes sympathetic nerve blocks can be both diagnostic and therapeutic if CRPS is suspected. But the bottom line is any significant vascular symptoms definitely need a proper workup to rule out primary arterial or venous problems like actual clots or blockages.
Okay, so moving on to the physical exam. Clearly this is super important for NTOS. What's the doctor looking for?
The exam is really about assessing the degree of disability, identifying those aggravating factors, and trying to pinpoint the source of the compression. It starts with observation posture, how the person holds their neck and shoulders, then checking range of motion, neck, shoulders, arms, both active where the patient moves themselves and passive where the examiner moves them. They'll carefully palpate or feel for tenderness in key areas.
Like where?
Definitely the scalene triangle in the neck right above the collarbone. Also the space just below the collarbone and under the coracoid process, which is part of the shoulder blade that checks the pectoralis minor area. These are common trigger spots where pressure reproduces symptoms. And of course, a thorough neurological exam of the arms is essential to check sensation, strength, reflexes, and rule out other nerve issues lower down.
And those provocative tests, the ones designed to bring on symptoms.
Right. These aim to temporarily narrow the thoracic outlet or stretch the nerves to see if it reproduces the patient's typical symptoms. One of the most useful is the elevated arm stress test, or EAST, sometimes called the Roos test.
How does that work?
The patient holds both arms up, elbows bent, sort of like a stick-em-up position, and then they slowly open and close their fists for up to 3 minutes.
And what happens in someone with NTOS?
Often, their characteristic pain, numbness, or tingling will come on pretty quickly, maybe within 30 seconds or a minute. They might feel heaviness or fatigue and might not be able to keep going for the full 3 minutes. If someone can do the EAST easily without any problems, it makes NTOS less likely.
What about the Adson maneuver? I feel like I've heard of that one.
Yeah, Adson's test is another classic one. The examiner feels the radial pulse at the wrist while the patient takes a deep breath, holds it, and turns their head fully towards the side being tested, sometimes extending the neck back slightly.
And what are you looking for?
A significant decrease or complete disappearance of the pulse suggests potential compression of the subclavian artery between the scalene muscles or under the clavicle.
But is that specific to NTOS?
That's the catch. While it can be positive in NTOS, especially if there's arterial involvement, a lot of perfectly healthy asymptomatic people also have a positive Adson sign. So by itself, it doesn't diagnose NTOS, especially the neurogenic type. It just indicates potential arterial compression in that position.
Okay, so physical exam is crucial, but maybe not definitive on its own. What about other tests? Imaging, nerve studies.
Right. Diagnostic tests are often used more to rule out other conditions than to rule in NTOS. Plain x-rays of the neck and chest are important, though.
Why? What can they show?
They're good for spotting bony abnormalities like that cervical rib we talked about, or maybe an old healed first rib fracture, or unusually long transverse processes on the vertebrae that could narrow the space.
What about CT or MRI scans?
You know, standard CT and MRI are often surprisingly normal in NTOS.
Really? Why?
Because the compression is often dynamic, related to position and muscle tension, or caused by soft tissue structures like those fibrous bands, which might not show up clearly or look definitively abnormal on standard scans. Even if an MRI shows, say, the brachial plexus looking slightly crowded in the scalene triangle, it's hard to be certain that's the actual cause of the patient's symptoms.
But they're still useful.
Oh, absolutely. They're very valuable for excluding other potential causes of arm and neck pain, things like a herniated disc in the neck pressing on a nerve root, shoulder problems like rotator cuff tears, or even tumors, though those are rare.
The source mentioned newer MRI techniques, though. MR neurography.
Yes, that's an evolving area. MR neurography uses specialized MRI sequences to get much more detailed images of the nerves themselves. It can sometimes show swelling or signal changes within the brachial plexus nerves that might suggest injury or compression. It might even offer some functional information.
So potentially more helpful in the future.
Potentially, yes. It's not yet a routine diagnostic standard for NTOS everywhere, but it holds promise for improving diagnostic accuracy down the line.
Okay, what about the electrical tests, EMG and nerve conduction studies, NCS?
This is another area where NTOS is a bit unique. Standard EMG and NCS are typically normal in most cases of NTOS.
Why would they be normal if nerves are being compressed?
It's likely because the compression is often high up, near the nerve roots, before the nerves have branched out much. And again, it's often intermittent. Standard EMG and NCS are better at detecting problems further down the nerve or more constant severe damage affecting the motor nerve fibers or their insulation.
So are they still worth doing?
Yes, definitely. Primarily to rule out other nerve conditions that do show up on EMG and NCS, like carpal tunnel syndrome, ulnar nerve entrapment at the elbow, or radiculopathy from the neck. Ruling those out helps strengthen the suspicion for NTOS.
Is there anything on those tests that might be suggestive of NTOS?
Some newer research suggests that certain specialized sensory nerve conduction tests might be more sensitive to the type of nerve involvement seen in NTOS. And if conventional EMG and NCS do show significant abnormalities related to the brachial plexus, particularly involving the lower trunk, CAT1, and there's no other explanation like a disc herniation, that might actually indicate more severe, potentially longer-standing nerve damage.
And that might affect prognosis?
It might. The source suggests that positive EMG and NCS findings in that context could point towards a poorer outcome after surgery.
Interesting. Okay, one more diagnostic tool mentioned was scalene muscle blocks. How do they work?
This can be a really useful diagnostic and potentially therapeutic procedure. It involves injecting a local anesthetic, like lidocaine, directly into the anterior scalene muscle, guided by ultrasound or EMG.
And the idea is?
The idea is if that muscle is indeed compressing the brachial plexus and causing the symptoms, temporarily paralyzing it with the anesthetic should relieve the compression and therefore the symptoms.
So if the patient's pain, tingling, numbness gets significantly better for a short time after the block.
Exactly. If they get temporary relief of their typical arm and hand symptoms and maybe the tenderness in their neck also decreases, that provides strong supporting evidence that the scalene triangle is the problem area. It's considered a good predictor of potential success with surgery aimed at decompressing that same area.
What about Botox injections? Are those used similarly?
Botulinum toxin, Botox injections into the scalene muscles, are sometimes used more as a treatment option, aiming for a longer-lasting muscle relaxation than a local anesthetic block. The results can be variable, though, and there are potential side effects, like temporary swallowing difficulties if it spreads. So it's an option, but with limitations.
Okay, so putting this all together,
Yeah.
making the actual diagnosis of NTOS sounds like it's not based on one single test.
Definitely not. It's really a clinical diagnosis, meaning it relies heavily on the doctor piecing together the whole picture. The differential diagnosis, the list of other things it could be, is pretty long.
Like what? Remind us.
Carpal tunnel, cubital tunnel syndrome, ulnar nerve at the elbow, rotator cuff problems, cervical disc disease, fibromyalgia, even just non-specific neck and shoulder pain, brachial plexus injuries from other causes. The list goes on.
So how do they narrow it down?
By careful history, really listening to the pattern of symptoms, what makes them better or worse, a thorough physical exam focusing on those specific signs and provocative maneuvers, and then using the diagnostic tests like imaging and EMG mostly to exclude those other possibilities.
And there are clinical criteria.
Yes, various sets of clinical diagnostic criteria have been proposed. They usually involve a combination of things like having the primary symptoms, pain, paresthesia, in the typical distribution, having symptoms worsened by overhead activity, specific findings on physical exam, like tenderness over the scalene triangle or a positive EAST result, and ruling out other conditions. Meeting these criteria helps identify patients who are most likely to have NTOS and potentially benefit from treatment.
All right, so let's say someone fits the criteria, other things have been ruled out, and the diagnosis is likely NTOS. What's the first step in management? Does everyone jump to surgery?
Oh, definitely not. For almost all patients, the initial treatment is conservative management, and the cornerstone of that is physical therapy.
But not just any physical therapy, right?
Yeah. Absolutely critical point. The source emphasizes this strongly. The patient needs to see a physical therapist who has specific expertise and experience in treating thoracic outlet syndrome. Standard shoulder or neck rehab protocols often don't work well for NTOS, and sometimes the wrong exercises can actually make symptoms worse.
Why is specialized therapy so important? What do they do differently?
A therapist experienced in TOS will do a very detailed assessment first. They look closely at posture, head position, shoulder blade position, and movement, scapular mechanics, clavicle angle, spinal alignment. They assess muscle imbalances, which muscles are tight, which are weak, how are they being recruited during movement.
So identifying the specific biomechanical issues contributing to the compression.
Precisely. They look for things that might be narrowing those critical spaces.
Yeah.
The scalene triangle, the costoclavicular space between rib and collarbone, the pectoralis minor space.
And then the treatment focuses on correcting those.
Exactly. The therapist plays a huge role in educating the patient about posture, breathing patterns, and activities that might be aggravating their condition. Then they design a very individualized exercise program.
What kind of exercises?
It often involves gentle stretching for tight muscles, like the scalenes and pectoralis minor. Exercises to improve posture and strengthen postural support muscles, like the deep neck flexors, rhomboids, serratus anterior. Techniques to improve nerve gliding or mobility. And strategies to retrain movement patterns and breathing mechanics. Sometimes they might use taping or temporary bracing to help unload the compressed areas or improve posture.
So it's quite comprehensive.
Very. It requires active patient participation and needs to be progressed carefully based on the patient's response. The goal is to reduce the mechanical stress on the brachial plexus.
And how often does physical therapy work? Can it avoid surgery?
For many patients, especially those with milder or earlier symptoms, specialized physical therapy can lead to significant improvement, sometimes complete resolution. That's always the primary goal of successful conservative management.
What are the success rates like?
It's a bit hard to pin down exact numbers. Studies from specialized referral centers, where patients tend to have more severe or long-standing NTOS, often report maybe 20–30% success rates with PT alone in that specific population. But it's thought that in the broader community, the success rate for conservative treatment is likely much higher, preventing many people from ever needing surgical consideration.
Okay. But what if physical therapy, even specialized therapy, doesn't provide enough relief? If the symptoms are still really disabling?
That's when surgical treatment comes into the picture as a potential option, but only for carefully selected patients who haven't responded adequately to a good trial of conservative management.
Right. Let's talk about the surgical side then. Our source gave a bit of history. It didn't start with nerves, did it?
No, interestingly, the earliest surgeries in that anatomical region were actually for vascular complications associated with cervical ribs, things like aneurysms or clots in the subclavian artery. Cervical rib syndrome was recognized quite early on.
When did they start operating for nerve symptoms without a cervical rib?
A key moment was in 1927 when Adson and Coffey described cutting the anterior scalene muscle and anterior scalenotomy specifically to relieve pressure on the brachial plexus, even in people without a cervical rib. The actual term thoracic outlet syndrome didn't come along until 1956.
And then rib resection became popular.
Yeah, over the next few decades, removing the first rib, often through the armpit, the transaxillary approach became quite common, especially in the 70s. The idea was that removing the bony floor of the outlet would create more space.
But there were some issues with that approach.
There were. While the incision could be cosmetically appealing, the results weren't always clearly better than just scalenotomy. And, concerningly, some reports highlighted a risk of permanent nerve injuries with the transaxillary approach, possibly due to the limited visibility and need for significant arm retraction.
So thinking evolved again.
It did. There was a shift towards ensuring complete decompression of the nerves, which often meant fully releasing the scalene muscles. This led to more surgeons favoring the supraclavicular approach going in from above the collarbone because it generally offers better visualization of the entire brachial plexus and scalene triangle.
So today, what are the main surgical options for NTOS?
The two workhorse procedures are still the transaxillary first rib resection and the supraclavicular approach, which usually involves scalenectomy, removing scalene muscle tissue, and neurolysis, freeing up the nerves, often combined with first rib resection as well.
Let's break those down. The transaxillary approach, what are the key features?
Okay, transaxillary. Incision in the armpit. Main advantage is often considered cosmetic, as the scar is hidden. It allows for removal of the first rib, particularly the back and side portions, and partial release of the anterior scalene where it attaches to the rib. It can also address some abnormal fibrous bands.
What are the downsides?
The main limitation is visualization. It's harder to see the entire brachial plexus, especially the upper roots, and the whole scalene triangle. This can make a complete scalenectomy and thorough neurolysis more difficult. There's also that historical concern about potential nerve injury from positioning or retraction, particularly to the long thoracic nerve or lower plexus trunks. And if vascular repair were needed, it's much tougher from this angle.
Okay, now the supraclavicular approach. Incision above the collarbone.
Right, usually a horizontal incision just above and parallel to the collarbone. The big advantage here is exposure. It gives the surgeon a wide, direct view of the entire brachial plexus, from the nerve roots coming out of the neck down into the outlet, as well as the subclavian artery and vein and the scalene muscles.
So what does that allow the surgeon to do?
It allows for a really complete anterior scalenectomy, often removing the middle scalene muscle too if needed. Crucially, it permits thorough neurolysis, carefully freeing the nerves from any surrounding scar tissue or bands under direct sight. It's also the best approach for removing cervical ribs or dealing with complex first rib abnormalities. And if vascular reconstruction is necessary, it can be done through the same incision, maybe with a small extension below the collarbone sometimes.
So better visualization seems to be the key advantage there.
Generally, yes. Many surgeons prefer it for NTOS because of that comprehensive access to all the relevant structures.
What about the pectoralis minor muscle? Sometimes that's involved too, right? A pec minor tenotomy.
Good point. If clinical exam or specific tests suggest that the space under the pectoralis minor tendon in the chest is also a site of compression, sometimes called hyperabduction syndrome, because symptoms worsen with raising the arm high, then releasing that tendon, a tenotomy, might be done.
As part of the main surgery, or on its own.
It can be added onto either a transaxillary or supraclavicular decompression. Or in some select cases where the pec minor seems to be the primary problem, or maybe in someone who's had prior TOS surgery, it might be done as an isolated procedure through a small incision below the collarbone.
Got it. So after someone has one of these surgeries, what's the recovery like? Post-op management.
Typically, they'll get a chest x-ray right after surgery to check the lungs. Pain control is important, managed with medication. If a drain was placed, it usually comes out in a day or two.
What about activity?
Early on, they'll likely be advised to avoid excessive overhead reaching or heavy lifting for several weeks. But gentle range of motion and resuming physical therapy fairly soon is usually encouraged to prevent stiffness and help with recovery. Most people can gradually return to normal daily activities and light work within, say, 4 to 6 weeks, maybe longer for heavier jobs.
Does everyone get complete relief?
Not always, especially if the NTOS was very severe or long-standing before surgery. Some residual symptoms can persist even after a technically successful decompression. Long-term follow-up, maybe yearly, is often recommended.
And like any surgery, there are potential complications.
Yes, those serious ones are relatively uncommon with experienced surgeons. The most feared is injury to the brachial plexus nerves themselves.
Is that risk higher with one approach?
Historically, permanent nerve injury seemed more associated with the transaxillary approach, perhaps due to the visualization issues. With the supraclavicular approach, temporary nerve irritation from retraction or manipulation can happen, but permanent injury is less common because the nerves are usually directly visualized. Temporary dysfunction of the phrenic nerve can occur after the supraclavicular approach, maybe around 10% of cases. This causes temporary paralysis of one side of the diaphragm. It almost always recovers, usually within weeks to a few months, but it's important to ensure it resolves before considering surgery on the other side if needed. Lymph fluid leakage can also happen, but minor leaks usually resolve on their own.
Okay, the crucial question. How well does surgery actually work for NTOS? What do the results look like?
Evaluating surgical outcomes for NTOS is actually pretty challenging. Our source points out that reporting is really variable. There's no single standardized way everyone measures success.
How are results usually described then?
Often in broad categories like excellent, good, fair, or poor, based on symptom improvement and functional recovery. Plus, many older studies lump all types of TOS together, neurogenic, venous, arterial, which makes it hard to isolate the results specifically for NTOS. Follow-up time also varies widely between studies.
But overall, is surgery generally considered beneficial?
Yes, despite the reporting challenges, meta-analyses and reviews generally suggest that surgical decompression is beneficial for the majority of appropriately selected NTOS patients. It seems to be relatively safe and leads to meaningful improvements in function and reduction in symptoms for most people.
Does the accuracy of the diagnosis play a big role?
Absolutely massive. The chapter really hammers this home. Accurate diagnosis and careful patient selection are paramount for achieving good surgical outcomes. If you operate on someone whose symptoms aren't actually from NTOS, the surgery isn't likely to help.
What about results for specific procedures? Scalenectomy alone?
Anterior scalenectomy by itself isn't performed much anymore for primary NTOS. The long-term results generally weren't as durable compared to procedures that also include first rib resection. Historical success rates varied a lot.
Transaxillary first rib resection.
That was very common for a long time. Pooled data from various studies suggests overall good or excellent outcome rates averaging somewhere around 80%.
And the supraclavicular approach with scalenectomy and rib resection.
Similar ballpark. Collected studies suggest average good excellent outcome rates around 77%.
So, roughly similar success rates reported.
In terms of those broad categories, yes. Interestingly, though, the chapter mentions one long-term comparative study.
What did that find?
It compared transaxillary rib resection, scalenectomy alone, and the supraclavicular approach with scalenectomy and rib resection. It found that while initial success rates were pretty similar across the groups, the level of success tended to decline gradually over time for all the procedures. And by 10 or 15 years out, there wasn't a statistically significant difference in outcomes between the different approaches.
Huh. So maybe the specific technique is less critical than other factors in the long run.
That's one interpretation. It highlights that NTOS can be a persistent condition for some.
Are there factors that predict who might not do as well with surgery?
Yes, the source lists several things associated with diminished success. These include things like the injury being work-related or involved in litigation, having symptoms for a very long time before surgery, coexisting major depression or other chronic pain syndromes, having really diffuse symptoms throughout the whole arm and neck, and importantly, not having had a good, even temporary response to a preoperative scalene block.
Does having a cervical rib make surgery more successful?
You might think so, but interestingly, no. The presence of a cervical rib or an abnormal first rib doesn't necessarily guarantee a better outcome. However, if a cervical rib is present, the surgical plan should definitely include removing both the cervical rib and the first rib for the best chance of decompression.
Any difference based on age?
There's a suggestion that adolescents might actually have more favorable outcomes compared to adults, perhaps because the condition is less chronic or entrenched.
What about situations where surgery doesn't fully work or symptoms come back?
That can happen. If symptoms just never really improve after the first surgery, that's usually termed persistent NTOS.
Why would that happen?
Often it might mean there was another underlying condition causing the symptoms that wasn't NTOS, or perhaps the surgical decompression wasn't complete. For instance, maybe after a transaxillary approach, the scalene muscles weren't fully released, or upper plexus nerves were still compressed. Reoperation strategy depends heavily on what the first surgery was.
And if symptoms get better but then return later?
That's recurrent NTOS. Most recurrences tend to happen within the first couple of years. Again, the approach to reoperation depends on the initial procedure. If someone had a transaxillary rib resection initially, a redo usually involves a supraclavicular approach to perform a thorough scalenectomy and neurolysis. If the first surgery was a supraclavicular scalenectomy without rib resection, then reoperation might involve adding the first rib resection. Repeat neurolysis might also be beneficial in recurrent cases due to scar tissue formation.
Okay. Lastly, the chapter includes an algorithm, a kind of flowchart for NTOS. Could you give us the quick version of that?
Sure. It basically summarizes the process we've been discussing. It starts with a thorough history and physical exam. Then, suggests using imaging, X-ray, maybe MRI-CT, and nerve tests, EMG-NCS, primarily to rule out other conditions. A diagnostic scalene block can be very helpful. If NTOS seems likely based on all that, the first step is conservative management specialized physical therapy. If symptoms remain disabling despite good PT, then surgery is considered. The choice between transaxillary and supraclavicular approaches depends on surgeon preference, the specific anatomy, need for exposure, cosmetic factors, and ensuring other causes are ruled out.
Great. Well, that brings us towards the end. Let's try to boil down the key takeaways from this deep dive into neurogenic TOS.
I think the main things are NTOS is a complex nerve compression syndrome in the thoracic outlet. It often involves a combination of anatomical predisposition and some kind of trigger, like trauma or repetitive strain.
And diagnosis is tricky. It's primarily clinical, relying on the symptom pattern and physical exam, using tests mainly to exclude other causes.
Right. Treatment starts conservatively with specialized PT. Surgery, usually transaxillary or supraclavicular decompression, is reserved for those with persistent disabling symptoms who don't respond to PT.
Surgical outcomes are generally positive for well-selected patients, but success can be influenced by various factors like symptom duration and coexisting conditions. And long-term results might see some decline over time.
And remembering that ongoing debate about diagnosis highlights the need for really careful clinical evaluation for each person.
Absolutely. So here's a final thought for you, our listener, to chew on. Given this complexity, the diagnostic challenges, and the range of treatments, what does the very persistence of NTOS as a recognized, albeit debated, condition tell us about that really intricate relationship between our anatomy, how we use our bodies, and our subjective experience of pain? And maybe what further questions does this raise for you about the long-term impact of both conservative care and surgery for people living with NTOS?
Good questions to ponder.
That wraps up our deep dive for today. Thanks for joining us.